Okay, we're now going to perform the examination of the chest and the lungs. And we have already gone ahead and asked our patient to go ahead and remove his shirt to begin the assessment. We're going to start with the inspection of the chest and the lungs. So the first thing we're going to be looking at is measurement of the anterior to posterior portion of his chest, and basically it's from the front to the back of his chest, and we're going to be comparing it to the transverse size of his chest, which is basically just from side to side here. Normally what we see is patients will have an anterior to posterior measurement that is much smaller than the transverse, and most of the time about half of the size of the transverse area of the chest. We're going to go ahead and start to inspect the size and the shape of the chest and the lungs, basically paying attention to making sure that he doesn't have any barreling of the chest in the back, such as we see in sometimes in the people that retain a lot of oxygen, such as in our COPD patients, asthma patients, and things like that that develop like humps in the back of the chest. Now we're also going to look at the symmetry of the chest, making sure that one side does look symmetrical to the other one. Now they're always not going to be perfect, but you can use one side to kind of compare to the other one, such as from the sternum to the right here must look just about the same from the sternum to the left, which is what we see here. And then we're going to go ahead and take a look at the different areas of the sternum and down, which is basically here at the xiphoid process. And this is where the ribs kind of bifurcate here in a fashion that should create what they call a costal angle of about 90 degrees. And then you have your ribs that should connect to the sternum at about a 45-degree angle. And you should, at times, unless the patient does have subcutaneous fat that does cover it, but sometimes you will be able to see the intercostal spaces. So all of these things are things that you can look at just upon inspecting the chest. Now another thing that we look at is the skin color. We do a brief just visual, making sure that we, again, don't see any discolorations, no cyanosis or pallor that may be indicative of some type of respiratory failure. Another thing that we look at is the nipples. We want to make sure that there's only one pair. We don't have supernumerary nipples. Also want to make sure that we don't see any venous patterns here on the chest, anywhere along the chest, as this could be indicative of some type of cardiovascular abnormality. Now sometimes we can even tell of the nutrition of the patient just by looking to see how much the ribs actually protrude. So all of these things are things that are important to watch for. And then we're going to go ahead and focus on the respirations of the patient. Now when we do this, we're going to go ahead and time ourselves on a watch that has seconds involved. And we're going to go ahead and time the patient. You can use either 15 seconds, 30 seconds, or the complete 60 seconds to measure how many breaths per minute the patient takes. Now, the normal amount should be anywhere from 12 to 20. So in this case, we'll go ahead and use a clock that we have here on the wall. We'll go ahead and just measure how many times he breathes in and breathes out just by looking at the chest rise. So we're going to go ahead and time this. That would be 1. That would be 2. That would be 3. That would be 4. That would be 5. So then you would do something like 5 times 4 to complete your 60 seconds in a 15-second period. And that would give you 20. So anywhere from 12 to 20 is normal. So this would be considered a normal number. Now when you look at these respirations as well, you want to make sure that they're not labored, that he's not having any retractions or bulging, that he's not using his accessory muscles. The respirations need to be normal, not labored, and they need to be just in a regular pattern and not agonal or in distress. So then we're going to go ahead and look at basically the chest wall movement. We want to make sure that when he breathes in, both sides do rise symmetrically, and that you don't have one side going higher than the other one, because this can be indicative of maybe a lung that is not inflating properly. Now, whenever you're checking the respirations, you want to make sure that the patient isn't breathing too fast, in which case it would be called tachypnea, which is any breathing over 25 respirations per minute, or maybe he's breathing too slow, which would be what we would call bradypnea. There's also other ways of describing respirations, such as how deep the respirations are. In a case where they're very deep, we would say that they were hyperpneic. And just the opposite of that would be hypopneic, and that would indicate a very, very shallow breath. In cases when we have Kussmaul respirations, these are normally deep respirations or hyperpneic respirations, along with tachypneic respirations. So the patient is not only just breathing deep, but also breathing very, very fast. And then you also have Cheyne-Stokes respirations, where a patient is breathing regularly and then all of a sudden goes apneic, and then this apneic period is followed by a crescendo decrescendo respiration, and then again followed by a regular breathing pattern. And then last but not least, the Biot respirations are normally those respirations where they're just doing whatever they want. Everything is kind of irregular. The depth of the respirations can be shallow, can be deep. It just kind of varies from time to time. There's no real pattern. You have apneic episodes here and there, but again, there is no real pattern to it. So with Biot respirations, you really don't know what you're going to get ever, because there's really no pattern in it. Now, there's other ways to be able to assess the patient, and one of the 4 ways is basically looking at the lips of the patient, making sure that he's not pursing his lips when he breathes, kind of doing that sort of thing, where that would be indicative of just starving for oxygen, because maybe the lungs aren't doing their job correctly. Or you can also look at his fingers, looking for any type of cyanosis there, looking at the nails for any clubbing that he may have, and then also looking at the nares, making sure that he doesn't have any flaring. We're going to go ahead and stop there for now. We have completed the inspection portion of the chest and lungs. We're going to go ahead and continue with the palpation on the next video.